Hello to everybody. It's Fabio Sciarretta speaking. I'm very happy to say good morning, to afternoon, and good evening to all of you that from all over the world, all over 65 countries, are joining this new ICRS, very interesting and updated webinar on hyaluronic-based regenerative repair of the knee. We have some great speakers with us. First of all, the master in cartilage repair, Brittberg from Sweden. Then we have Pablo Gelber from Spain, Boguslaw Sadlik from Poland, and I have the pleasure to introduce the next president of ICRS Society, Lisa Cohn, and she's from Italy, and she will also co-moderate with me this beautiful event. And I'll give the word to Lisa, please.
Thank you very much, Fabio. Thank you very much. Welcome to everybody. So we are very happy to see you now online, and we hope really to see you live in Berlin in April. I hope it will be possible, but really for the moment we try to go all around the world online, as Fabio already said. So without losing any further time, I will thank Annika for the sponsorship of this webinar, and I would give the first lecture to Boguslaw Sadlik, which will talk about the osteochondral reconstruction on the knee. When allow the weight bearing. Please, Bob, floor is yours.
Thank you, Lisa. I had the pleasure to see Lisa live last week in the Wrocław, because we have a Polish Arthroscopic Society meeting, and then we could see face to face.
That was impressive. That was really impressive in Wrocław, because it was really something returned back to more than 1,000 people on the conference, and it was really nice to see the people, the room crowded, and that was nice.
Exactly, 1,100 people comes. Everybody was happy to see alive, to talk alive. But also we was lucky a month ago to see Fabio, Brittberg and Fabio Sciarretta in Budapest. We also have a lucky to participate in second and just to have a time for us. But backing to the topic, I would like to tell you something about biological index osteochondral reconstruction and weight bearing period for this, because there is very important things. Today we're talking about the Hyalofast. Hyalofast is a biodegradable non-woven pad that is composite of HYA11. It is a benzyl ester of hyaluronic acid. So it's a matrix for collect cells. Following works of Alberto Gobbi from Milan, when he used bone marrow aspirate concentrate for bending this scaffold before implantation, we go forward by this road, and he's got the excellent results proven by MRIs that this combination works very good for cartilage defects. However, everyone knows that we have very big problems with osteochondral defects, especially if they are very deep, or bone cyst appears underneath subchondral bone. Then everybody thinks about the OATS, mosaicplasty, or sandwich techniques by other colleagues using ACI in the past. Currently we use matrices bended with some scaffolds. But when we talk about the shape of the jointed surface, we have to, in my opinion, we have to pay more attention for surface shape. When I invented some kind of sandwich technique, which consists of the bone chips mixed with fibrin glue to getting the concave shape of the surface. and then I'll show you shortly how to do it. Sometimes we have a subchondral strips, subchondral necrotic bones, which is even invisible during arthroscopy. Then we see on the MRI, and when you can palpate it, then we can see that there is a big gap underneath cartilage. Even it looks quite good. In this situation, we have to remove all the necrotic bone until bleeding bottom, and to prepare for implantation. There is a technique of a dry arthroscopic implantation using the special retracting tools. And during this phase, I make an assessment of the defect, and then I prepare some biological implant, which consists of the bone of autologous, of allogenic, of mixed with together bone chips, which must be very much fragmented in the small pieces, and then I abandon it with the bone marrow aspirate. Alberto Gobbi used the concentrate. Currently I use only single bone marrow aspirate due to financing reason in Poland, and then I put some drops of fibrin glue, make a mixture, and this mixture I load in a special pipe, special piston, special barrel with piston, which helps me to introduce it into the joint during the surgery. Usually, when it's a small defect, I make it arthroscopically, but more often I make a small incision. I put the scope on the side, and under control of the scope, I implant this by hammering this BIOR implant of bone chips into the defect, and then I form cone shape of this before this surface shape before further implantation. On the I put cover some fibrin glue, and there is a small new remarks, but currently we use fragmented autologous means cartilage also for covering this defect before implantation of Hyalofast, because it helps osteochondrogenesis, what is proven by many authors lastly. Then when we have a bottom from the bone chips and cover it, making the shape of this, covered with the fibrin glue. Finally, we implanted Hyalofast on this, and there is very easy into arthroscopy manner, and the arthroscopy manner or mini-invasive, because Hyalofast is very flexible, very nicely, really nicely is to manipulation. And what is very important is very adhesive. So it means that when it keeps the bone, until we make a final surface on it, and then we create some of the osteochondral inlay, like you see here from the two or three separated layers. The problems comes when we follow patients by rehabilitation protocol, because there is a soft tissue. Everything is soft tissue, especially Hyalofast, and we try to avoid collapsing of the regenerate and controlling weight bearing. And there is an issue of my topic, because if everything is all right, we have a great shape of the surface, but if not, it could be collapsed, and when we have a problem. So we use additional allodic procedure. Sometimes we do high tibial osteotomy or distal femoral osteotomy, it's needed, but very often we use just special braces, and of course protocols, post-op protocols. When we look for other big authorities about the protocols of non-one-way period, we could see that there is a very difference. That there is some authors wants to avoid very early. Some authors wait very long time until they allow. So maybe there is not the topic to go through all the rehab protocols. It's very visible on the net, but I just could show you here that there is a very big differences I hear, and sometimes they are very complicated. Brian Cole, for example, he advocate full weight raises from the start until toleration of the patients. Also, Kevin Stone advise weight bearing, but starting from the 4 or 6 weeks with crutches as is tolerated. From 1st to 4 weeks is a forbidden weight bearing, and we have also very brave protocols like Timmy Sports Medicine by William Robertson, that weight bearing is allowed in the brace lower than 0 degrees just from the 0 week. So it could be confused. So I really don't know what is the right way. So I try thinking logically how it should be, and I try to thinking about the rehabilitation protocol. That we make this schedule. This schedule consists of 9 points, which 9 information which I have to give to my rehab protocols. First is time of immobilization. That is very important because biological osteochondral reconstruct as an inlay is very soft and very, is not fixed by hard, only by glue. So we need, in this technique, we need the time of complete immobilization, because during this time, the fibrin, the blood clot, it's turned in the fibrin clot, and that give us very good connection where we not moving with the joint. Second issue is the shape. Shape is rebuilt by opposite joint surface, and this opposite joint surface give us protection and keeps the shape. After this biological process, we don't afraid so much adhesions because there is a short period. Then we go to just directly to the movement with all tolerated range. I don't make any limit for range of motion. I see only of the toleration of the patients, and I see for unweight bearing, do not weight bearing this area of the implantation. So I have a phase of full passive motion with traction of this area. For example, in the condyle we have 2 weeks. From the 2 weeks we start this patient. In the femoral condyle with BIOR, we do week from the 3 weeks. In the trochanteric differently, but full passive motion turns with traction, turns in times of full passive motion, and then we turn into full active motion with the using of muscles. The next issue is a weight bearing. We divide in the 2 phases. One phase is a partial weight bearing, when we advocate to weight bearing between 30 and 50% of the weight of the patient body. And after this, we start with the full weight bearing. But we have to know in this period when we are allowed, and there is a key. Next is the running, jumping, full strength training, tri-clubbing, full sport activity. Next phases, which are in the special range. It depends how big is the defect and where is the defect, but it is not topic of this issue. When we look at into the knee, we see that there is a differences between chondral and osteochondral defects using the simple, for example, Hyalofast, like one layer, or 2 layer with the bone and the Hyalofast. We have differences between periods, and also there's a big difference when we do have a defect in the patellofemoral joints. For example, I'll show you later on. Some words about the braces. We use the braces with the controlled unweight bearing medial or lateral, and we follow we follow this patient with the MRI protocol, and we can see here that after 3 months, of course the regenerative is not ready, but we're looking for shape. If shape is okay, then we allow more aggressive weight bearing. If shape is not enough, it's not growing up and not cover all the shape, then we stop with the bearing. And when the patient is very good leading, you can see that it turns this biological osteochondral inlay turns very slowly, but turns into two-layer bone and cartilage surface like in this man. So when we look in the protocol, the big differences with the weight bearing are in the trochlea and femoral condyle, where the most often is BIOR used. So we can see that, for example, the femoral condyle, we have to wait 5-6 weeks, depends how big is the defects. But in the trochlea, with the full extent knee, we can allow to fully weight bearing from the first week. For the 2 weeks, we can fully load, because on the trochlea, in the trochlea during gait, it's a no big weight loading of this area. That's why there is a big differences between femoral condyles and trochlea or patella when we allow the patient weight bearing. What is show this schema. So there is always I'd like to present you about my idea of this protocols after osteochondral defects. There is an example of the man who has not quite young, because he's 69, and he's got this problem on the femoral coil with this necrotic bone. And after this protocol, he is completely healed after 1 year. Okay, thank you very much for your attention.
Thank you very much, Bog. It's been a very interesting topic, and I think we'll have a lot of discussion about weight bearing. And thank you also for having introduced and spoke about Alberto Gobbig, that certainly has been one of the first using hyaluronic acid scaffolds. While Pablo gets ready, I want to emphasize the fact that all the participants, we're having over 400 registered participants from over 70 countries. You can just get ready with a question or write them in the chat if you want. And so in this way, we can answer you or get them for the question and answer at the end. Now, I'm very happy to introduce Pablo Gelber, who will speak about Hyalofast and Nanofracture in the knee osteochondral defect treatment. Please, Pablo, your time to go.
Thank you so much. Very controversial topic, Boguslaw. It's very interesting. It's very different comparing to what I do to my patients. So this is regarding immobilization and weight bearing. So this is something that we can discuss later in the at the end of the webinar. So this is also controversial, and somehow it's not. I mean, in the OCD treatment is not probably the best indication for this kind of treatment, but in some selected cases you can use it. At least I have it in my treatment protocols. Of course, when we talk about OCD, there are different stages. We are not going to talk about OCD specifically. There are different stages, and we keep this kind of regeneration cartilage, so replacement cartilage treatments for grade 4 or very selected also grade 3 OCDs. There are so many different kind of treatment about cartilage and what we can do in OCD that it's impossible to to summarize all of them. I will try to focus. I did a schematic division of what I believe is best for this kind of injuries. Of course, when we are talking about micro nanofracture, we are talking about making small holes that will allow that the mesenchymal stem cell from the bone marrow will come up to the created defect to fill and to try to push them to differentiate into something like in a cartilage-like tissue. If we only do this, we all know that microfractures obtain a pretty decent, good outcomes at short follow-up, but fast enough, the results, the clinical results worsen pretty fast. The ultrastructure of the cartilage is very sophisticated. I'm not going to talk about this. It's very clearly very difficult to reconstruct or to obtain something similar to this. If we compare what we have in a normal cartilage, hyaline cartilage, what we obtain at the microfracture, we can easily see that the histology is highly different. Also, what we obtain depends not only in how we do the technique, but what instruments that we use. It depends on the diameter and shape of the hole. For example, if the diameter is bigger, the compaction of the bone around in the created hole is bigger, which will prevent the mesenchymal stem cells to go into the defect. It happened the same when we compare different lengths of the holes. The longer the hole is, the better we can obtain, the better cartilage-like tissue we can obtain. Comparing here, you see here, comparing 6 millimeter versus 2 millimeters long holes. It's much better or closer. We obtain more collagen type 2 and saphenol when we have a bigger hole. That's the philosophy of the nanofracture design, which compared to microfracture is much thinner, only 1 millimeter in diameter, and much deeper, around 9 millimeters. This is the technique, just for the people who have never seen how the nanofracture is performed. Comparing to microfracture, it's much more delicate. We can create many more holes close to each other, with a much lower risk of collapsing one hole into the other. The problem with this is that, like in microfractures, it can lead to uneven distribution and phenotype differentiation due to the leakage, because nothing is maintaining what we are calling to the defect from the bone marrow. So that's why already many years ago, the scaffold, the idea of the scaffolds come out to the area of cartilage transplantation. And regarding scaffold, also there are so many that it's impossible to summarize, but of course the ideal scaffold would be biocompatible, structurally stable, support load from cells, and also reabsorbable. There are few studies comparing scaffold versus isolated microfracture plus scaffold comparing to isolated microfracture, and also show that the short-term follow-ups are similar, but at mid-term follow-up, we can keep a little bit better clinical results than if we only perform microfractures. And this is the time of describing a little bit the Hyalofast. Boguslaw also did so before, but we know that it's a biodegradable hyaluronic acid-based scaffold for like cartilage regeneration. It's uniform, a single layer structure. And as I said before, talking about the scaffolds, it plays the role of entrapment, or try to entrap the mesenchymal stem cells that came from the bone marrow through the created holes. As I said before, now we are going to focus in the grade 4 OCD, stage 4. And I just divided the different scenarios where we can find this kind of defect in OCD stage 4. In some cases, like in this one, when the defect is not only the cartilage, but really deep into the bone, of course, the Boguslaw technique can also be done, but I prefer when the defect is so deep into the bone to go for something. Fortunately, I have availability to perform fresh osteochondral allograft, as we are seeing here. Also, this is a case I did 10 days ago. He was a 17 years old male patient who had 2 attempts to repair this OCD, which of course failed. And in this case, And in this case, as you can see here, it was totally irreparable, this cartilage. So in this case, I perform a bone dowel fresh osteochondral allograft technique, as we are observing here. We harvested the osteochondral allograft, we impacted softly, and this is the result. Then there are 2 other scenarios. In one scenario is when the OCD, although of course the OCD is not only the cartilage layer, but also the subchondral bone. When this subchondral bone is mostly kept, is only preserved, in those cases you can perform this standard AMIC technique, just obtaining first, of course, a healthy bone bed with a curette, and then performing a nanofracture, as I showed in the video before, And in a dry technique, we introduce the Hyalofast in a cut syringe, 5 cc syringe, as we are going to see here now, which is a very easy trick to allow the Hyalofast to get into the joint in a dry state, so we can more easily modulate and palpate by palpation with the proof. We can keep it on the defect. I like to also to use to seal with some fibrin glue, like tissue cold, like this one, which is not mandatory, but at least for my conscience, it's made me more to be calmer than if I don't use it. And the third scenario will be, let's say, some intermediate scenario where the OCD is of course involving the cartilage layer, but also at some degree the subchondral bone. So in this case, please, I call the attention to everyone. We are always thinking about autologous bone in the iliac crest. We are talking about, we are knee surgeons, and we have a very good source of cancellous bone right in the knee, in the proximal medial aspect of the tibia. In fact, it is a better quality regarding cell constitution and also a higher volume than in the anterior iliac crest. So remember that it's very easy. The morbidity is much lower than what we can have in the iliac crest. We make a small open book technique. We obtain the autograft and then we close it. I like to also seal it, which is of course not necessary, but as we are using the tissue cold for the Hyalofast, we can also use part of this to seal this window. Once we have the bone arthroscopically or open, I'm not crazy of arthroscopy in the way if it is too big, we can also do it in an open way. When we feel the defect, as similarly to Boguslaw showed in his technique, in his video, then we proceed with the biodegradable hyaluronic acid-based scaffold, so-called Hyalofast. So to summarize, we can obtain in OCDs this aspect of the repair. In some cases, it's not necessarily anything else than nanofractures previously to introduction of the Hyalofast or the hyaluronic acid scaffold. But in some cases, which the defect of the bone is somehow bigger than that, I recommend always using the first after debridement of the ill bone, replacing this by cancellous bone autograft from the proximal tibia, and then using the scaffold on it. Thank you so much. Remember also about the 16th World Congress in Germany next year, and also if you want to see some complex cases, I usually post in my Instagram account. You are invited to follow. Thank you so much.
Thank you very much, Pablo. Really, really interesting. So now it's our pleasure to introduce one of the lions, one of the founders of chondrocyte transplantation, one of the founders of ICRS, Mats Brittberg. So we are looking very much forward, Mats, on your experience on the Hyalofast and Hyalograft for cartilage repair. Please, thank you.
Yes, hello everyone. Let me see here just. Yes, so hello everybody, and thank you, Lisa and Fabio, for starting up with this meeting discussing about the use of hyaluronic acid scaffold for cartilage repair. And I will talk a little about my experience using Hyalofast and Hyalograft. And you know, the ideal cartilage repair scaffold should provide an immediate support to the chondrogenic cells. It should also have mechanical properties matching those of the native cartilage tissue. And it's also important that it gradually degrade at the same time as the seeded cell or the cells from the bone marrow are starting to produce their own matrix. So allowing an optimal integration between the new formed and native tissue. And the scaffold should also allow chondrogenic cells to be organized three-dimensionally to prevent the loss of the cell phenotype. If you look upon hyaluronan, it's present in all soft tissues of higher organisms, and in particular high concentration in the extracellular matrix of cartilage, and also important to remember in the mesenchyme of a developing embryo. So it's a tissue that is quite well known for the body. Cross-linking and coupling reactions are two ways to obtain a modified, stable form of hyaluronan. And the HYAF that we are using is the class of hyaluronan derivatives obtained by such coupling reactions. So if we look upon the nice studies by Grigolo and co-workers, they found that IF11 has cell adhesive properties and is stable in aqueous solution for over 3 weeks. That's the time you could understand before it starts to dissolve, and then at the same time that the cells have started to produce their own matrix. A three-dimensional HYAF scaffold also supports the proliferation of different types of cells, but the cells that we are of interest to use are the chondrocytes and also chondrogenic mesenchymal stem cells. And if you look also by the work that was started by Grigolo and co-workers to develop this product, they found that after 4 days of seeding, the cells are on the surface. And after 7 days, the cells start to bridge between the fibers. And actually, if you look upon the use of HYF11 that we have used also in our lab, the cells are everywhere in the scaffold after about 2 weeks' time. And then it's the time to use it for implantation if you're using for chondrocytes. And you could see here the nice section that Sebastian Concaro at our lab has produced. He put a cell-seeded scaffold that had been grown in vitro for 4 weeks into the subcutaneous tissue of a skid mouse, and you could see the nice cartilaginous production after 8 weeks in a vivo situation. And that is what we hope should be the same in the joint. Well, when we are going to treat patients clinically, and when we are to treat lesions, we often overestimate the size of the lesion. And if you see the size for a normal bone marrow stimulation like microfracturing or nanodrilling, most often you shouldn't treat more than up till 5 millimeters, because if you see on the condyle, 5 millimeters is quite a large defect. And in indications that has been for microfracturing, it's up till 2 centimeters, and it's extremely large defect that I don't believe is good for just bone marrow stimulation. So at least for lesions up to 2 centimeters, you need some sort of scaffolding, and we should look upon it a little more. So when you are to treat lesions, chondral lesion or slightly osteochondral lesion up to 2 centimeters, you could use deep drilling, the nano drilling, and combine it with a protecting surface, the top support. Initially developed as the AMIC technique with the chondroguide membrane, but now you could also use this HYF11 support as a modified AMIC technique. But also when you are using the situation when you have large defects, lesions that are more in size than 2 centimeters, you need a cell-supported scaffold, a cell-seeded scaffold with chondrocyte like the Hyalograft C, which in our country we call also HS, mean that we have used human serum. And you could see the burn score when you have cultured cells, chondrocytes in this scaffold. You see the best situation is at 14 days, and that's the day when we are to implant our chondrocytes in this HYF11 support. When we are to use the HYF material for either direct implantation with bone marrow stimulation or with chondrocytes, you do the same technique. You debride the lesion to vertical walls and clean bony base. You may do an abrasion arthroplasty to make an anchor and hole in the bottom of the defect. You fill the defect with fibrin glue. I most often use a vet joint because it's sometimes difficult if you empty the joint, because then the joint will collapse and you will have more difficulty to see if you do it transarthroscopically. As an alternative, you could use carbon dioxide arthroscopy. Here you see the resection, the debridement of the lesion. Then you put in your your HIAF scaffold, and you don't need to be exact in fit because you could fold it and you could put it under some compression. And if it's a deep defect, you could even put several layers, what I called a millefeuille technique. Here you see you put some fibrin glue after you have sized the implant, and then you push it through the portal with a special grasper with smooth surfaces, and you push it into place with your arthroscopic probe. And then you could do flexion, extension, movement to firmly form the implant in the secure position and surface alignment. Here you size the scaffold. It could be without cells or with cells, the same technique. You put some fibrin glue on top of it. You put it and fix it with a grasper, and you are to introduce it via the portal like this. Here you have an osteochondral defect that you need to do osteochondral grafting. You do grafting first. You push your graft through like a syringe, and then you put several layers, the millefeuille technique of the scaffold on top of it. Bone graft, fibrin glue, your syringe with the tip cut off, and then you push your graft into the defect under compression. And you see it here, and then you put your cell-seeded or non-cell-seeded graft into the place, and you could put the several layers on top of it, put some fibrin glue, and still it's a wet joint. And then it bulging a little, so you have to compress it. You could use a tonsil elevator, and you do the flexion extension test, and it's compressed slightly. Here you could see on the left, just implanted HIAF11 scaffold with cells at that time, and at the right side, you see it after 1 year repair. In the post-operative rehabilitation, I'm using a brace locked in extension for 2 weeks, allowed full weight bearing or as much weight as pain decides, because it's stable in rotation, and compression is good for the stimulation of the cells in the scaffold. And as long as it's not a very large defect, you have a surrounding cartilage that protect the weight bearing. If you have a very large defect, you could after some time use an unloaded brace to unload that area. You could treat patella transarthroscopically. If it's a lax patella, you put K-wires in it and introduce your scaffold. You could use a vector guide to drill retrograde and push your graft through the drill hole into the defect area and cover the bottom of this area with bone grafts. I'm also using the HIAF11 scaffold for cartilage autograft implantation tips and the Kai system with cartilage fragment. You have heard it earlier that you could use it also for this type of scaffold. You could see here a fragment with a nice outcome of cartilage, and it's in a vitreous situation here in HIAF11 scaffold. There are now different versions of this fragment technology. Here's one version where you mix your autologous fragments with allogenic fragments and use PRP without any scaffold. But I have a version of the Kai's technique called the Kafrima cartilage fragment implantation membrane augmented technique. You debride the lesion, you put fibrin glue in the bottom of the defect, then you harvest cartilage with a special graft net collector, and you see to the right the collected mini fragment that are to be introduced into the defect with a syringe or a special 2-in-all that you could also use. You push it like a cream into the defect, into the fibrin glue, and then you cover it on top with a HIAF11 membrane to protect it during the first phase of repair. Also for ankle injuries, you could use this same technique with here in the ankle, I call the handkerchief implantation technique, the way that the magician puts the handkerchief through the hand in order to make it to disappear. You make a drill hole through the malleolus. You use a vector guide to find the exact spot of the cartilage defect area. And then you use the handkerchief technique to push your graft, seeded or non-seeded, into the defect area where you spread it out and compress it. So you could use this technique as a modified aiming procedure with Hyalofast. You could use it as a cell-seeded HYF11 Hyalograft technique, or as a Kafrima Kais modified procedure. A combination with bone graft is also possible. If you have a very large defect, you could do it mini open to cover the anterior part in a mosaic fashion with your HYF11 matrix, and then you use a vector guide to reach the posterior part to treat that part, and you cover it in several layers in a mosaic plaster fashion. And then you could also combine it with bone chips if you have an osteochondral defect. So finally, I wish you all good luck with your future use of a biological augmentation like the HYF11 membrane or similar types of membranes for cartilage, both chondral and osteochondral repair. And I thank you very much for your kind attention.
Thank you very much, Mats, for the so enthusiastic experience that each time you're bringing to us. Now I'm very pleased to introduce my friend and the next president of ICRS, Elizaveta, that will speak to us and give us all our great experience on Hyalograft C, chondrocyte transplantation with the long-term results. Please, Elizaveta.
Thank you very much. So I will bring you to the long-term results of this technique, which all started with Matt's paper together with Lars Peterson in New England Journal of Medicine about first generation chondrocytes transplantation. Now the new generations probably don't know very well this technique, because sometimes we're talking about chondrocyte transplantation to young people they don't even know. And this was the most pioneering technique, appeared in late 90s and very, very widely used in the beginning of 2000. And we also have very nice results and very long-term follow-up of a first generation technique, which always been, interesting technique for the cartilage reconstruction. Once again, back after the first generation had some difficulties I'm not going deeply about. The scaffolds arrives, and the scaffolds arrives first with cells. So the cells were widely used, combined with the scaffolds. And I have some nostalgia looking on this slide, because this is a slide from our paper in 2002, back in 2002. And that was all these products with chondrocyte transplantation plus scaffolds on the market. And now they are basically, none of them are on the market due to the problems, especially the regulatory problems, because the cells have to be compared to drugs, and also to the economical problems. So most of these products are not on the market yet, but I hope it will be some return the chondrocytes in the next future. Because why? I will tell you very shortly why I think so. And obviously we started using Hyalograft C as a product first, and the Hyalograft C was the product coming from Italy. And it was one of the first, together with Macy, to appear on the market and to be introduced in clinical practice. And it was the same membrane like is used now as a Hyalofast, but seeded with autologous chondrocyte, which was really very good support for growing a chondrocyte, as Mats already showed. And this is just only papers, clinical papers coming from our clinical experience, only from our group, not telling about other groups. So you can see what's really been widely investigated, these patients. Back to 2000, Professor Marcacci have developed the first arthroscopic implantation technique, which I just schematically represent here. So it was really, like Mats said, it was almost that was what Mats showed in his presentation. with dedicated instruments. I don't know if it still exists or not, but we're not using the syringe, but using the same tool of instruments. We are really very simple ones, just the drill, the sleeve, the drill, and the applicator, which was using also to cut the implant. So it was very precise, a little bit mosaic plasty, snowman more than mosaic plasty, trying to be very precise and avoid any type of immobilization of the implant. So it was rather easy to use, rather quick and straightforward procedure, and was fully done arthroscopically. We were also fully doing arthroscopically deep osteochondral lesions. And once again, I think Max was extensively showed the technique was more or less the same technique we're using for autologous chondrocyte transplantation. So in doing arthroscopic autologous bone grafting, it was possibly done also with the same instruments, pressing the autologous bone, mortualized bone inside the defect. And then with the only difference as far as the chondrocytes, we were doing it 6 months after the bone gets stabilized, get the positioning on the chondrocyte membrane over it. And what's about the results? So my talk is focusing on the results. So it's really what we want. So this is one of the first papers which came out, which once again, one of the first comparatives, was not randomized, it was a comparative trial from Hyalograft C in microfracturing in relatively young and active patients. And we see that at 2 years of follow-up, there was no difference, but the difference showed up at 5 years of follow-up, because in terms of AKDC, in terms of Tegner score, these patients perform much better on 5 years of longer follow-up respect to the microfracturing. And also looking on the highly sportive patients, because it's always a big problem to keep young sportive guys with traumatic cartilage defects away from sports for a long time, because with chondrocytes, you have to keep them away from competitive sport at least for 10 months. But it works as a return to sport at 5 years on a pilot follow-up, because it was really important difference in Tegner score and important difference in AKDC score in the patients between microfracturing and regenerative technique like Hyalograft C. So probably for the young athletes, it's always, this is regarding Hyalograft C, this is regarding any scaffold technique. So it's always worth to invest time in your patient, and there may be longer rehabilitation and longer technique, but having the perspective to the reconstruction, real reconstruction of the joint, because as Pablo showed, what we get with microfracture is definitely not with cartilage we wanted. So when it was 2012, it was already some long follow-up showing up. And once again, Hyalograft C is one of the really champions in terms of clinical studies published. And up to was the longest follow-up was 7 years. So let's look now. Now we have to look who published on more than 10 years of follow-up. And once again, we see Hyalograft C, a lot of Hyalograft C publication up to 10 years or even more than 10 years of follow-up. And I want to share with you the last baby coming from Giuseppe Filardo group, who looked over our arthroscopic patient, which was all arthroscopic Hyalograft C transplantation. That's why we're talking not about patella, but their trochlear and femoral condyles defects, including the traumatic, some degenerative, traumatic, and also OCD. So maybe mostly distributed between this lesion. And follow-up was minimum 15 years. So at least all the patients reached 15 years follow-up. And it was just significant number of patients, as you can see. And the follow-up was pretty impressive, because consider that 15 years of follow-up, it means that the patients, youngest one were 20, 25 year old. Now they are almost 40. And the youngest from this group, so it's 40 years old patients, are 60. So it was sort of some physiological down in the activity. But if you look on the AKDC score, basically patients does not decrease their activity, they does not reduce their active life. The same from ECOWAS and mostly the same for Techno score. So it's really, it was just some slight physiological decrease in Techno score, but due to the age, but not mostly due to the knee. So this was really nice results on long-term follow-up. And worst outcomes were found in elder patient, obviously, female sex and degenerative lesion, respectively traumatic lesion, and cases who already failed previous treatments. So if you look at a failure analysis, basically interesting thing that we have, most of the failed patients fails up to around 6 years of follow-up, and then the failure HRS pretty much stays the same. So if you were mostly okay at 5-6 years of follow-up, you have a good possibility to stay long life with your new cartilage grown. And once again, degenerative cases and female sex were bad predictors for these patients. And if you look at the surgical failures on 15 years, we have 15% of surgical failures. So it means that implant was removed and something else have been done. And we're going up to 22 of failures if we consider also clinical failure. So patients have never been reoperated, but we are not happy with their knee, which is really very good outcome for 15 years of follow-up. So just to sum up, we have the chondrocyte transplantation on the Hyalofast membrane, which was called Hyalograft C. The very nice long-term results on the follow-up have been implanted arthroscopically, and it disappeared from the market for some reasons that had nothing to do with the clinical efficacy of this implant. And we really, new products will need to be on this next level, so need to be pharma products, which is rather difficult, but I'm pretty confident that we will see chondrocytes products back on the market. So thank you for your attention and really hope to see you. I remind you the deadline of 15th of October, which has been extended here, the mistake was been extended to 29. So we're really looking for you in Berlin in April to see each other. Okay, thank you for your attention.
Thank you very much, Elizaveta, for the wonderful, very interesting long-term experience. We have still some minutes for the discussion, so I'll pick up a couple of questions we have from the chat. The first, I'll go for the two questions so you can quickly go for the answer. The first one is for Mats, and Arthur Leskov is asking, in the handkerchief technique, do you prepare the site of implantation like shaving the edges of the lesion, or you just putting the scaffold in place? And then I would like to have Bog and also Elizaveta answering, because there's a colleague, Chulumbat, that is asking if we have experience on the stem cells. So certainly, Bog, you published with Alberto Gobbi the Hyalofast plus the bone marrow, and Lisa has a quantity of experience to add to that. So please, Mats, the first. Okay,
if I understand the question right, if I do really debridement, and I think the debridement is important. Certainly you should have vertical walls. New studies have shown you could also have slightly sliding walls, but you should always debride, because the surrounding cartilage could be covering dead chondrocytes, and it's always good to have a clean area for the new repair tissue to climb on. So debridement is very important.
Thank you very much. Now let's have a look to what we can add on Hyalofast plus stem cells.
Yeah, stem cells. It is a good question, because stem cells are in the bone. I always have a question when I put the bone and under and cover it with the Hyalofast. I really need to put bone marrow aspirate. But usually, like Alberto showed us, it's better to make a concentrate, but normal bone aspirate. Honestly, I have not such possibility to make this kind of expensive procedure in Poland, because Hyalofast is a is a not cheap piece of Frizzolin. That was the most expensive piece of Frizzolin in the world. But I observe my results in the MRI, and I try to comparing when I put bone marrow aspirate or bone marrow aspirate concentrate on the both patients. Honestly, I don't see really differences on the MRIs. But I need more time to make an honest randomized control trial with this, and then I will be ready to answer your question.
Elizaveta, do you want to add something?
I'm not using the combination of bone marrow concentrate with the scaffolds, if not on the patella or in the ankle, because for my opinion, it not makes a lot of sense for me on the femoral condyles, because you have already very good blood supports in the femoral condyle, if not for particular reasons. I'm using a lot of stem cells as injectable treatments, or for inside bone injections and so on, but not in the combination with the scaffolds. But I want to make a question regarding the bone reconstruction to Pablo. Pablo, you showed that you're using nanofracturing plus Hyalograft C. Nice and elegant technique. You're using it in when you don't have any bone loss. So we had the previous experience that I showed, and also Mats, doing bone grafting, autologous bone grafting in combination with coverage with the membrane. We had rather good results for this. You are using allografts. I never used osteochondral allografts in such a young guys, because all this have been afraid, to put something allogenic in such a young person for the very, very long-term results. So what are your thoughts about why you prefer allograft and not combination of autologous bone plus membrane?
Well, as I said, I do sometimes use bone autograft, cancellous bone, when the bone defect is not too deep. Conversely, to what you're saying, fortunately, I had the availability to use both of them, and I seen more predictable and better results when I use in deeper defects the fresh osteochondral allograft. In fact, the best results I've obtained in all my series of 80 cases with fresh osteochondral allograft are in cases with OCD for young patients. So, and I also had to remember that you only have to transplant no more than 7 or 8 millimeters of bone as a layer to allow for creeping substitution. We previously, of course, tried to decellularize it with high strength pulsatile irrigation. So I'm not afraid of anything regarding allograft, and it hasn't been described any kind of rejection, at least in the knee, some in the ankle, but not in the knee. So I'm not aware of having something in allograft, because I also use allograft sometimes in some reconstructions, and the allograft also with some cells.
So Mats, what do you think about? You also showed your CD technique. You're more for autologous bone.
Absolutely, I agree with you. For small, we normally use the patient's own bone. Sometimes I have to mix it with synthetic bone, because the resorption is a problem. And if I have a very large bone defect, I'm using from the bone bank, but normally I could solve most of the young patients' osteochondral defect just with autologous bone grafting. But certainly, if you have a very large defect, you have to consider osteochondral graft as a solution, because the long-term results are quite good. If you see in reports, for example, from Canada, that have a huge experience using osteochondral graft. But normally, I do the same as you do, Lisa. So.
Okay, so another question that I see, because we a little bit run out of time, but I think this very important question. This was one of the first ones on the chat. What do you do with meniscus, guys? So how do you approach? So if you have a meniscus turn, meniscus loss, and what coming first, meniscus on cartilage? And so what is your first about meniscus? Because I think it's very important. So start with Pablo and Mats, then Bob.
Yeah, first comes alignment.
The first comes alignment, for sure, for sure. The question was about meniscus, but first comes alignment. I agree.
I know. Well, I mean, one plays the role. They both plays a synergetic effect. So I will never treat chondral defect without sufficient meniscal tissue in that compartment. And the other way, also, we all know that we transplant the meniscus with a grade 3 or 4 chondral defect, the survival rate of that allograft will decrease significantly. So I try to first think in alignment, and then if there is a combination of both, I treat it both.
So you do the combination with meniscal allograft and cartilage with the same inside the same surgical session, or you stage it?
Many cases.
Many cases, so allograft of meniscus plus cartilage plus osteotomy, the same session or stage?
Yeah, and ligament reconstruction too, yeah.
Plus ICL, right? Quite a lot of surgery altogether. But I basically agree. Okay. But the question is, you never put meniscus and don't reconstruct for grade defect. Just put only meniscus, like French school suggests to do. Leave cartilage alone and put only meniscus plus osteotomy. And leave cartilage there.
Yeah, for your question is extremely important, because I think that the meniscus is even more important than the cartilage in our joint. So we have to consider a lot about the meniscus, and we should to all costs try to do a meniscal repair if you have a problem with the meniscus in the young patients. When we come into the middle-aged patient with degenerative meniscus, is more difficult, but still we have to consider it. In our country, still we don't have logistics to use allograft meniscus. It will be more in the future, but in that sense, when we have to do something to the patient, we are very freely to use unloading osteotomy, and unloading osteotomy is an extremely good operation for patients, even for small defects with the malalignment. For large defects without malalignment, you have to consider tibial unloading osteotomies, varus or valgus. And if it's a small defects and a slight narrowing of the joint space, you could also use unloader braces as an alternative, but we are very happy with osteotomies, I would say.
Yes, if I could say my opinion is the same as Mats Brittberg. I have now really good result with the meniscal transplantation. Meniscal transplantation and fitting the allogenic is extremely difficult to do it, and sometimes the surgery makes a bigger loss of the cartilage and the osteoarthritis development and leaving it with a meniscus. I also think that only correction of the alignment osteotomies as currently the proper way to protect losing meniscus. If you have a lesion of meniscus, you should try. I try to make all I can for the meniscus repair. Tomek Piątek has his technique with the wrapping meniscus with the concentrate, and I did some meniscus, but I think that there is not same meniscus as I need. The special problems with the pressing out the meniscus, with the extravagation meniscus out of the gene line, and when we have a problem with the anchoring of the meniscus, it exists, it doesn't work. So I think that currently only osteotomies give us good results, but meniscus allogenic transplant or either artificial meniscus probe are still not perfect.
Thank you very much.
Thank you.
I think these are very interesting take-home messages. The discussion is very nice and very interesting. We're already over from 7 minutes. I can assure all the audience that the questions we have in the chat will be uploaded to the speakers and they will answer. I want to thank deeply Annika for having let us possible this event. And I also want to invite all of you the 17th of November to stand with us and participate in the webinar on osteochondral allograft, both in the shoulder and in the knee. So I want to say goodbye from my side, but I invite Elizaveta to say the final words.
So thank you very much, Fabio. Just we are a little bit run late out of time. I'm very sorry because it was a really, really nice discussion. And I thank everybody very much. And once again, I hope to see everybody live in Berlin. And don't forget, you still have a couple of days to submit the abstract. Okay?
Absolutely. 2022 will be back live.
Thank you very much. Thank you very much.
Enjoy.
It was a great meeting.
Thank you. Bye-bye.
Bye-bye.